This presentation examines a case of human-to-human transmission of rabies via transplantation of a kidney in 2013. The word rabies conjures up images of frothy-mouthed vicious dogs, angry wildlife, and perhaps sad endings to movies we remember as kids. What is often not discussed in the Western world are the number of people that become infected and subsequently lose their lives from this insidious disease. But rabies doesn't seem like a threat here in the US. And while it's true that surveillance activities and animal vaccination have greatly reduced the risk of rabies infection in humans, in other parts of the world the threat is still very real. The World Health Organization estimates that over 60,000 humans die worldwide from rabies. The majority of these are transmitted by a bite from an infected dog. Rabies, a lyssavirus, cannot cross intact skin, requiring direct exposure to a mucous membrane or through cuts and tears in the skin. Upon exposure, the virus may incubate for a long period of time, days or even up to a few years, making diagnosis difficult for clinicians. However, early clinical symptoms are generally nonspecific, resembling those that occur with many other viral infections. These prodromal symptoms are followed by acute neurological symptoms as the virus attacks the central nervous system. This paralytic or furious phase of rabies is seen in 2/3 of patients. Its hallmark symptoms including fever, agitation, confusion, hydrophobia, and hypersalivation, which is caused by encephalitis. Without intervention, the disease is 100% fatal. While human-to-human transmission of rabies is thought to be rare, there are reported human cases associated with organ transplantation. One such case occurred in 2013, which came to light following clinical presentation following a kidney transplant in a patient in Maryland. This case represents a massive undertaking on the part of public health response to track down all potential contacts that may have been exposed, in addition to medical personnel involved in the transplantation procedures. In February of 2013, a patient from Maryland was diagnosed with rabies following clinical presentation that began as persistent hip pain and advanced to declining neurological capabilities. The patient reported no animal exposure events. However, he had received a kidney transplant more than 17 months prior to symptoms, which is much longer than any previous case of transplantation case of rabies. This prompted an examination of donor tissue stored from 2011. Brain tissue tested positive with genetic sequences that matched viral genetic material from the recipient. It was confirmed that transplantation was the source of this infection. The additional organ recipients had to be quickly located and treated with post-exposure prophylaxis to save their lives. Contact investigations would also need to be conducted for all those that had been in contact with these recipients, now more than a year after exposure. Response had to be well coordinated and involve multiple agencies. An incident command structure was initiated. For the donor and each recipient, the likely infectious period had to be calculated based on hospital admission records and any clinical symptoms that were verified. Contacts were located through various records available, including social media and military flight records. Over 2,700 hours were spent conducting interviews for this investigation, and 55 of the 564 interviews received post-exposure prophylaxis based on their contact with saliva, tears, neural tissue, those that were involved with the patient care, and those that cannot recall their exposure with both the donor or any of the recipients. This massive undertaking, while impressive, begs the question, is there a method to screen patients that present with neuropathy prior to organ donation? As part of continued approach to improve transplant safety, future efforts may include recommending post-mortem rabies diagnosis on neural tissue from potential donors with unexplained encephalitis.